Well, hello everyone. It's so nice to see so many familiar faces and some new faces. Thank you for being here tonight. For those of you that whom I haven't met yet, my name is Susan L. I'm Vice President and Executive Director of the Foundation for Barnes-Jewish Hospital. I'm so happy that you could be here this evening. The Leading Edge series is one that is really, really very special and so exciting. I learn something every time. It's a spectacular opportunity to be up close and personal with physician scientists who are literally at the leading edge, hence the name of the series, in their medical practice at Barnes-Jewish Hospital. Because you're here tonight, I'm guessing you share my enthusiasm about learning what is truly at the leading edge of medicine. We've learned over the last years that while our donors make gifts to support a variety of things, including patient care, education, and training, many support research. And the return on the philanthropic investment for research in medical research is not only better quality and enhanced delivery of patient care, it also very often drives the discovery and the next question to be answered and the next disease to be cured. And it takes a special culture to advance how science finds answers to those questions. So much of the discovery work of the Foundation is privileged to support comes as a result of the collegial collaboration across departments within Washington University and within Barnes-Jewish Hospital. It's an environment fostered by the faculty of the medical school at Washington University and within our hospital. This unique environment, and I was saying to our speakers, Dr. Kukulich and Robinson, that what they're going to talk about tonight, I think could only have happened right here on our medical campus in St. Louis, because it's a unique environment and it encourages collaboration and allows the kind of transformational work that we're going to hear them talk about tonight. But let me start at the beginning. Last fall, I received an email from Dr. Dennis Hallahan. Now, he's the chair of the Department of Radiation Oncology. We partner with him in philanthropy, and he introduced me in his email to Dr. Cliff Robinson and Dr. Phil Kukulich, asking me to meet with them just to hear more about what they're doing. And we did. And I have to thank Dr. Hallahan for making that introduction, because he has been the catalyst to make this bringing together tonight possible. In December, the New England Journal of Medicine published the results of their research in non-invasive cardiac radiation for ablation of ventricular tachycardia. I was looking for the other title that was up there because, so let me say that again, let me read that again. Non-invasive cardiac radiation for ablation of ventricular tachycardia. Now this is the coming together of radiation oncology and cardiology, two separate disciplines, two separate departments. And because of the culture that we have here on this medical campus, they're collaborating and working together. Well, the New York Times picked up that story and told the world that the treatment of this condition had forever been changed right here in St. Louis, and the rest, of course, as they say, is history. Now, these two physicians have a story to share, and I'm convinced it could only happen here because of the culture and the environment that we have and the partnership. Your interest in learning more tonight is another form of investment that we're so appreciative of, and we're so pleased that you could join us and be here tonight. It's my privilege to call your attention to those who are wearing name tags that look like this. They are members of the Foundation for Barnes-Jewish Hospital, and they are on the board. And they also make these kinds of programs possible. So be sure to introduce yourself and talk to them when you have a chance after the program. So without any more of my talking, I'm about to introduce Bob Cannon, who is president of Barnes-Jewish Hospital, group president of BJC, and he's going to introduce our guests. So welcome, Bob Cannon.
My mother would be very proud of me to have helped. It's nice to see so many friends here tonight. You really are in for a treat. This is going to be a terrific talk and educational session. And before I get on with some of the introductions, I do just want to highlighted note that there are a couple members of the Barnes Jewish leadership team here tonight. So over here is Mark Krieger, our Chief Financial Officer, is joining us tonight. Mark, thanks for being here. And if you haven't met Angeline Peters-Lewis, our Chief Nurse Executive and Vice President for Patient Care Services, she's joining us as well. So Angeline, welcome. It's really only so often that we get a chance to have these kind of get-togethers against the backdrop of what is really tremendous research results. And a time also just to recognize how very much the foundation does to support everything. So $29 million in research funding to WashU School of Medicine last year alone, which is really very significant. And we are very grateful for all that the foundation does to help us in all the research efforts that makes life so much better for our patients and families. So as Susan said, kind of going back to her clinician roots, we have some would say an unlikely pairing of a cardiologist and radiation oncologist. But for those of you who know the medical center well, one of the things that really makes WashU unique is the way that that investigators from different disciplines come together to work really on revolutionary breakthroughs. And I will tell you, this kind of approach goes all the way down to, say, the design of facilities and other things, where you look at ways to create encounters, ways for researchers and clinicians to come together, exchange ideas, sometimes in occasional ways, sometimes that really leads to very important breakthroughs. So tonight, as we hear about these really revolutionary treatments and non-invasively arrhythmias, this is really going to be a game changer in the cardiology world. And as you'll hear about some of the technology that's being applied here, this idea that you can accurately target a therapy to a beating heart with a breathing patient is really extraordinary. So a little bit more as our physician colleagues get introduced here, but both coming from these separate areas of medicine to relearn terminology and techniques and other things. But I think I'm going to stop with any deep introductions now and simply say it's my pleasure to introduce Phil Kukulich and Cliff Robinson. Dr. Kukulich is a heart rhythm specialist and associate professor of medicine at the Washington University School of Medicine, and Dr. Robinson is associate professor of radiation oncology. So without any more introduction, I'm going to ask our two physician colleagues to come up and tell us our tale here. So thanks very much and welcome.
Great, thank you very much. I'm a little bit more of a walker to try to keep things engaged here. This is quite an honor, quite a privilege for Cliff and I. My name is Philip Kukulich. I'm a heart rhythm specialist, as you heard. And this is really the interface of two disciplines that have never previously been together. And Cliff and I are going to introduce you to the concept of non-invasive cardiac radiosurgery. And we have questions all the time. People ask us, well, how does a cardiologist and a radiation oncologist get together? And it turns out that we have similar hobbies. We actually specialize in death, right? This is a graph that shows the most common ways that humans die. So in fact, on the green line, that's heart disease. So from the 1950s into 2014, heart disease is the #1 killer of humans. And the blue line is cancer. You can see that I'm doing a better job than Cliff is, right? But we're pretty close here, and it turns out these are the two leading causes of death. But more important than how we got together is the why. Why did we get together? We got together because sudden cardiac arrest is still the #1 cause of death in humans across the world. And sudden cardiac arrest happens for a number of reasons, but most commonly from an abnormal heart rhythm. When we had this important paper that got published in the New England Journal of Medicine, we had a neat interaction with Scientific America, and we did a fun podcast with them. So I'm going to let them kind of explain what this means for us. So can you turn on the audio for me? Thank you. Or not. Feel free to turn it up a little bit more. All right, I'm just going to tell you that sudden cardiac arrest is most commonly caused by an irregular heartbeat coming from the bottom chamber of the heart. It's called ventricular tachycardia. And this is what it looks like on an EKG. So on the top is a regular heartbeat. As we're sitting here, we have a heartbeat of anywhere from 50 beats a minute to 100 beats a minute. And when your heart goes into this life-threatening bad heart rhythm, it's often in excess of 200 or 250 beats a minute. And when it goes that fast, the heart simply cannot perform. The heart simply cannot fill, it cannot pump, and patients black out. And if you cannot restore that life-threatening heart rhythm back to the regular heart rhythm, patients die. And that's where this comes from. So this is a schematic of a heart. And one can see this yellow area and this brown area within it. The reason that people have irregular heartbeats is because there is scar that forms in the heart. The most common reason for scar is a heart attack. So in this picture, there's a heart attack here, and the arrhythmia happens because of electricity moving around and through that scar. We have ways of treating that. So we have medicines. You know us doctors, we always have medicines, right? So there's medicines. Here's the bad news about medicines. A, they don't work very well. They're about 50% effective each year. And B, they're really toxic. So about a third of patients have to stop these medicines each year because they cannot tolerate the side effects. We also have cardiac defibrillators. These are devices that are implanted underneath the skin, and they monitor and they watch for a life-threatening bad heart rhythm. And if it senses a life-threatening bad heart rhythm, it charges up, just like a paramedic would do with paddles, and delivers a jolt of electricity to the body to restart the heart. Hands on. So I brought some of these so that you can see what these look like. So this is a cardiac defibrillator. I'm going to let you put your hands on that and kind of take a feel for it. Cliff, you turn these off, right? Okay. Okay, good. I think these are turned off, so I think you're in good shape here. But this is what a defibrillator looks like. This is what it feels like. These are devices planted in and allowed patients when necessary. Can you take me back to this microphone instead? This would be better. Thank you. Good. And this is what it looks like when a defibrillator works. So I'm sorry to be a buzzkill here, but I'm about to show you a young athlete who is about to die on the soccer field. So you can tell which one he is. He's the one who goes down. There he is. He just died. He has a defibrillator in. It senses it. It's charging. Watch his feet. Watch his feet. He just got shot. He just got saved. And I'm good. I'm ready. Put me back in. It's amazing. So this was a patient who had had scar in his heart, had a defibrillator his doctors had already recognized, and was still playing high-level football, high-level soccer, and had an arrest on the field. And you would have known it because 10 seconds later he was alive and walking off the field. It's amazing. However, it hurts. It doesn't really feel good to get shocked. If it happens once, you're pretty happy about it that you're still alive. When it happens a second or a third or a fifth or a 20th time, it really affects the quality of life. And so what we have devised is ways to get into the body, find where the scar is, and maneuver long, skinny catheters inside a beating heart. We heat up the tip of that catheter and cauterize a portion of the heart. That sounds kind of crazy, doesn't it? I think it sounds pretty spectacular. This is kind of what I do on a daily basis. I talked to my 11-year-old son yesterday. I showed him some of the props that I'm going to show you. He was not impressed. He said, really? Why would you do such a thing? So you've seen defibrillators. I want to show you what a catheter looks like that we steer around inside the heart. So friends, this is a catheter that's inserted through an IV that's usually placed on the top of the leg, and this long skinny tube is threaded up into the heart. And if you look closely, you'll see that I can spin this around a little bit. I can curve it and move it around. And this was the part that my son was nonplussed by. He said, that's all? That's all you can do with it? Don't you have a remote control or a joystick or something? So I'm going to let you move these around. You can push and pull the plunger and pretend like you're a cardiologist here for a few minutes. So one of the questions or statements up front was, there's no camera on the end of it. And I agree. It certainly would be nice to be able to see what we're doing, right? We steer these catheters around inside the heart with x-rays or with other ways of tracking the tip of it, but in general, we don't see what's going on while it's going on. And let's keep in mind, again, this isn't a beating heart, a moving heart. And so that's where we stand right now, and I want to show you a little video of what that's like, because when we're trying to treat ventricular tachycardia, when we're trying to prevent shocks in somebody who has a scar in their heart, it's a long procedure. It takes a long time and it can be pretty difficult on patients. So here's a little video about what a catheter ablation is like. This is the room where it happens. You can see it's very resource intensive. There's a lot of circuitry, there's a lot of computers, there's a lot of manpower. We get into the vein in the leg. I'm speeding this up Benny Hill style here. This is the equipment that we use to go into the vein. You see these long catheters, these long sheaths, even a needle that we put into the heart. We insert these up into the heart looking at fluoroscopy or x-rays, and we usually are a little more gentle than that, push. But we do move these catheters around inside the heart, and we create a three-dimensional map, and we identify where the zone of scar is. We induce the bad heart rhythms. And then we can heat up the tip of the catheter to try to stop that from happening. Now, scar can be quite large. In this next picture, you'll see a map that we created, and scar is red, and purple is normal. And you can see half this person's heart is scar. It's huge. And when we go in to try to ablate, heat up the tip of the catheter, that usually takes anywhere from 30 seconds for each one of those dots to 3 minutes for each one of those dots. You can add that up and realize that this is an hour upon hour upon hour of ablation. And so at the end of the day, it's a 6 to 9 hour procedure. Patients oftentimes stay in the hospital 1 to 2 days. There's a 40 to 70% chance that it's actually going to work at 6 months. And there's a chance of complication that ranges from 4 to 12 or more percent. In fact, in the latest large database that we looked at, 1 in 20 patients did not survive a month. 1 in 20 was dead at a month for undergoing this type of a procedure. So it's a risky type procedure. There's a lot that goes into it. And so if you think about how this looks schematically, it's anywhere from a 40 to 70% chance that somebody is going to have more arrhythmia despite undergoing the 7-hour procedure. And why is that? There's some fundamental pieces that we need to think about. This is a cross-section of a heart. The normal is kind of that pinkish color, and the scar is that tan color. And if we got in closer at this cross-section, you can see the normal pinkish color has scar within and around it. And our catheters oftentimes come from the inside. And it may be difficult to see, but this is where we have done our catheter ablation, right here, and here, and here. And this patient's circuit is not in those locations. This patient's circuit is much deeper, and we can't reach with the tip of those small catheters that you've been passing around. So we need to think about approaching this in a different way. What I'd really like to do is be able to ablate that entire area a little bit deeper. Gosh, if only I knew somebody who had some tools to be able to deliver energy anywhere he or she wanted to in the body and try to do it in a very pinpoint way. Turns out I might know that person. So we have to ask ourselves, what if, right? The best ideas always are the what if. What if ablation wasn't so difficult? What if it wasn't so risky? What if we could make it actually a little more effective? And what if it was a little bit less invasive along the way? And so in order to do that, we have to think about ablating smarter. So how can we deliver energy in a better way? How can we map the heart in a better way? And one of the big obstacles that we need to overcome is the idea that we can see the diseased part of the heart without having to put a catheter into the heart. And we can do that. We have cardiac MRIs, we have cardiac pictures, but most importantly, we have a brand new technology that was actually invented here at Washington University that non-invasively maps the heart. And it's called electrocardiographic imaging, ECGI. So this is a little schematic about a patient who wears a vest, quite a handsome looking vest I would say, and gets a panoramic view of the electricity coming from the heart. The patient undergoes a CAT scan at the same time, and that way we get the patient-specific heart-torso geometry. Turns out that not all humans are shaped the same. So where your heart sits in the chest kind of matters. And so we can see, without going into the body, without doing a procedure, just by wearing the vest and doing a CAT scan, we can identify where the electricity is coming from on the heart. And so there's the map that we can see in a single beat without having to go into the body. So I can non-invasively tell you where an arrhythmia is coming from. And that's an important piece to this. This is an example of one of our patients that we treated recently. I'm not going to ask you to be a cardiologist, but this gray cap is where he had a heart attack. Red is the area where his arrhythmia was coming from. It's exiting right out of the area of scar. It is traversing through the scar and exiting right there. That's where we need to put our catheters, or maybe that's where we need to do better ablation. And so we also need to treat the diseased part of the heart more effectively, and ideally, I think, without entering the body. So with that, let me introduce Cliff Robinson, my partner, my friend, who will take you through the rest of this.
Thanks, Phil. That was a fantastic overview. You brought some really great props. I tried to take a 2-ton linear accelerator and fit it in the trunk of my Subaru, but it didn't quite make it here, so I apologize. So, what do we do next? I've been blessed to do my training and start out as a junior faculty and now advance through the ranks during a time in radiation oncology where it is really, and people use this term probably a little too much, it really is a renaissance. We are now able to do things with radiation that we could not conceive of doing in the past. And one of the big things is the development of something called stereotactic body radiotherapy, or SBRT. A confusing word, but functionally what it is the ability to give high-dose, precision, focused radiation treatment to targets anywhere in the body. Used to treat cancerous conditions from the head to the toe, maybe not so much the toe, but everywhere in between. And this is an example over here, I'll show you, where the colored area is a patient who has a inoperable lung cancer. This is a patient who, historically, if this was 15 years ago, their only option would be to receive 6 weeks or 7 weeks of daily radiation treatment with chemotherapy. There would be a lot of side effects with those treatments, and the chance of controlling that tumor would only be 50%, which is pretty lousy. With these treatments now, over a series of 1 to 5 sessions, not weeks, a week, 1 to 5 total treatments, we can give high-dose focused radiation, and we can have a chance of cure of 90%. And that's without a surgery, much to this consternation of the thoracic surgeons. So, and often there is little or no side effects. And so this is something that has been made possible because of all the advances in technology and computation and our understanding of what we can do. But again, you can see this is an example of a tumor. We're trying to treat the tumor. We're trying to avoid the healthy tissues. And avoiding the heart has been something I have prided myself for my whole career up until now. So this is an example of how we might deliver such a treatment. In this video, what we're seeing is if we're sitting in the machine, we're actually watching the machine deliver the treatment. We're sculpting and mapping and focusing that treatment down into the chest, and we're doing it in a big sweeping arc. And one of the really great things that's happened recently is that when we first developed these treatments, they would take something in the range of an hour or 2 to deliver. And now we can do it in less than 10 minutes. And that's really, really helpful for these patients that are sick and even have trouble just laying there because of their breathing. Now, as I mentioned, I've prided myself for my whole career on avoiding treating healthy tissues like the heart. But what if we could take those non-invasive maps that Phil showed us and all that imaging that allows us to non-invasively find the source of the arrhythmia and combine it with a treatment, and I move that radiation target directly into the heart. Do something that every professor that I had before me told me, don't ever do that. That's bad. But what we're doing is we're targeting the disease part. You have to have that visual. You have to think that he has no problem, Phil has no problem going in with a catheter and burning that area. We want to just do it in a non-invasive way. And so being at Barnes has allowed us to do that, because it's allowed us to do creative things, like take that map, and this is a prototype of one of the first pieces of software we developed that allows us to merge that map onto my planning CAT scan that we use for planning radiation treatments. And that's been something, again, that I think Susan is correct. It's really could only happen here. And so what have we done with that? Well, we've created this technique that allows us to non-invasively map and non-invasively treat, and we can do it with a single session. So we give a single high-dose focused radiation treatment to the diseased part of the heart. And we believe that it is faster and easier for patients. But I don't want you to take my word for it. I have my own video to show. So what is non-invasive ablation? So you don't get admitted to the cath lab. You walk in and you check in your sweatshirt. And so this patient right here is one of our early patients getting non-invasive radioablation. He goes in, he lays on a table here. You can see it's kind of a cushion that they lay on. They get aligned using lasers to make sure they're in the right place. They do a CT scan. The machine itself can scan the patient to get them in the proper position. And that clicking sound is just the machine counting off the little doses of radiation. But again, what you see is he's listening to music. He's just laying there. There is no lasers, there's no burning, frying, zapping. It's quite boring, actually. It's the way I like things. If I wanted things exciting, I guess I would have been a surgeon. So he just lays there. But then importantly, he walks out.
All right.
So he just received the world's fastest VT ablation.
Congratulations.
7 minutes. Yeah. That is a game changer. Because as far as I know, I don't think anybody's ever walked out of Phil's cath lab. They're usually wheeled out. And this has been inspiring, you know, being able to work with Phil on this. And so we've taken this now, and we've delivered this treatment now to 24 patients. 25 if you count somebody we recently treated who had a tumor. But these were the first 5, and these are the ones that started to get a little bit of the buzz. So let me walk you through this. The first 5 patients we treated were not on a study. They were treated for clinical need. These were patients with limited to no options. They had recurrent VT. They had been shocked many times. They were on maximum doses of medication. They had received multiple catheter ablations that had failed, and they had little to no additional options, except things like heart transplant, or maybe just giving it another go with a catheter ablation. And what we did is a single dose of radiation with the mapping that I just showed you. And in the graph we see here, this is a measure of the different events that they were having. So the defibrillator device itself can measure how often it treats the patient, how often it tries to pace them out of their arrhythmia, or how often it shocks them. And for some of these patients, as Phil had mentioned, they were being shocked many, many times. And so this is the burden before, in the 3 months before radiation treatment. On the left with all these colored lines, each one of those colored line is a different patient and their burden of arrhythmia. And then we deliver the treatment, and this is what happened. So in every single patient, we had a essentially elimination of the arrhythmia afterwards. Pretty exciting. Yeah. But I think important, and this is something I really want to give Phil credit for giving me an opportunity to work with him on this and help take care of these patients. A really important thing he mentioned was that these medications are toxic. I've seen people who have complained of severe nausea. It can affect the liver and the lungs. These medications are not good for you. And what we really tried very hard is we weren't okay with just seeing the arrhythmia get better. We also tried to get them off their medicine, and largely we were successful in these patients. So this generated a little bit of buzz. And she mentioned the New York Times article. And that's exciting for us, but I'll be honest, it's way more exciting for me to have our patients' stories told, for the brave people who were the first people to do this, and they deserve to have their stories heard. And so the very first patient was John Sumi. Dr. Sumi is a pillar of the community. He's an orthodontist who, as it turned out, took care of a lot of the braces of the kids of the nurses that work in my department. And so they knew him from that, not from this New York Times business. And he was the first patient to agree to do it. He had been having extensive shocks from his device, was on high doses of medication, had already had a catheter ablation which had failed. And when I met him in the hospital the first time, he was on the transplant list. That was really the option for him. He was hoping for a heart. And so he was, brave enough to agree to do this new treatment. And what we saw was that reduction right there. And so that's a great example. This is a patient, a true person who gets treated. Their story matters because he's not just a number, he's not just a statistic. This matters to them, and I've really gotten to see that as I've seen them follow up. And so after his VT improved, he left the hospital. He ultimately went to Italy, which had been on his bucket list. He went back to work, although he only went back to work long enough to realize he really wanted to retire anyway. So he ended up doing that. But ultimately, he ended up really getting to participate in his favorite hobby, which is playing with his grandson. And that's something that, this gets to me when they see that. So we've seen other people also pick up on this, and it's also allowed us to tell the stories of some of our other patients. And, Phil looks pretty good in that cover photo there. You look good, man. But, again, I think it's the stories of the individual patients matter. So, it is about the quality. We see this reduction, but it's not just the number, it's about the quality. And so I like this because Clarence Mankin is another one of the patients we treated, and his story was told in Outlook magazine, and I think that was a really nicely done piece, a very fair and balanced report, and it really allowed him to tell his story. And he's a gentleman who's actually a retired pastor and used to be extremely active. We just had a nice conversation earlier about activity and health, and he had proof. He had his pedometer. He was 10,000 steps a day. And then when his VT kept coming back, he did what a lot of people did. He stopped walking, he stopped driving, and he actually just stopped leaving the couch. His quality of life was awful. And then we did this treatment for him, and I think he describes it better than anybody else that I've seen them do this in print so far. He says, "I don't know if this will extend my life or not, but it has made the quality of my life much better." And at the end of the day, that's what we're doing this for. So just to hammer this home, as if I haven't really bludgeoned you over the head with this yet, this is another little piece. This is something that was done as a quick kind of 1-minute video to distribute to different networks. And this is Patty. And Patty was the very first patient that we treated on our prospective study after those 5 patients. And we'll see if this gets to play with the sound here. Can you play that for me?
When Patty Sweeney developed an abnormally rapid heart rhythm, she knew something was wrong.
You could just feel like your heart was just pounding really hard, like boom, 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 and like it was just going to jump out of your chest.
Patty has ventricular tachycardia, a dangerously fast heart rate often caused by scar tissue in the heart. When traditional treatments failed, she worried a heart attack was next.
I was too young for that, just way too young for that.
Then she found cardiologist Philip Kukulich and radiation oncologist Cliff Robinson.
These patients are oftentimes looking for any level of help, any hope.
The doctors are combining their expertise, shooting focused beams of radiation at the heart to destroy the scar tissue.
This was definitely the first time I had ever purposely radiated the heart.
The first 5 patients in their study collectively had 6,500 ventricular tachycardia episodes in the 3 months before treatment. In the 1-year follow-up, that number dropped to 4.
It's this almost on-off switch where you go from having a problem to not having a problem. And that flip, I think, is really impressive.
It worked for Patty.
I go to bed and sleep just fine now. And I don't lay there and worry.
I'm Marty Salt reporting.
So, inspired by those patients and those results, we moved forward and we did a prospective study. We treated an additional 19 patients. And that study, when we first put it together, you have to estimate what accrual is going to be, how long it's going to take. It's all for budgeting and how much time it's going to be. And we anticipated it would take a little bit more than 2 years to accrue. And we had no idea how many people were out there that were in need of this treatment. And that trial accrued in less than a year. And so it's closed, which means that we're getting close to reporting the results. No one has seen the results, but you're going to see the results. So, slightly different way to look at things. Each one of those lines is a patient. Each one of those lines, the length of that line, is again the number of events that they were having, the number of times the defibrillator was either shocking them back to life or pacing them out of the irregular rhythm. And you can see some people was a little bit, some were actually maxing out the chart. We couldn't put it on anymore. It would be a really long line. And so this is the 6 months before treatment. And you know, I will admit, when we first treated those patients and then we did the clinical trial, there was a part of me that was thinking, what if this was a fluke? What if we got ready? We got lucky. You know, it was just 5 patients. But then we treated the 19 and we saw the same thing. An average of 111 events before 6 months, down to 2 afterwards. I also like to take a moment, if I may. Each one of those bars is a patient who has required a lot of hand-holding, coming back to clinic for the research visits. And the person who has done all that has been Caitlin, who's sitting here in the audience today. She's our research associate. So if we could all give a hand to Caitlin. But even more exciting, St. Louis has now become the epicenter for this. So this has quite literally become a global phenomenon. Since our article came out, we've been contacted on a nearly daily basis by investigators all across the world. And at some point, I just couldn't put any more pins on. But what we see is that we've got the whole scope. The only part we're currently missing right now is Africa, but we're working on it. And these are people who have reached out to us. We're not going out and trying to sell this to the world. They've called us and they said, we want to participate. How can we be part of this? And so we've been working very hard to figure out a way to make that happen. But I think very proud that this is happening at this hospital system in St. Louis, and this is the epicenter. And so because we can barely keep up with those emails, and people have said, well, we want to come visit, we want to learn, we came up with the idea, we decided, clearly we're not busy enough, so let's go ahead and actually schedule a symposium. So we have actually officially launched, we're going to have a symposium where people can come from around the world and talk about this treatment, learn from us, share ideas, and that's going to be happening in September this year. And as of today, we just kind of went live with some of the registration. We already have people registered from the UK and Australia, so we'll having them come visit. So where do we go with this? What is the essential next step? So I've shown you the results. They look very promising, but we have to be cautious. We have to be careful. We have to be good investigators and good clinicians, because we know that there's potential risks here. We're treating patients who have limited options, but with any treatment, whether it be catheter ablation or whether it be radiation, there's a risk that something bad can happen from the treatment itself. And so we have to continue to study this. But more importantly, in addition to continuing to study this, we have to make sure that this remains safe and effective as we start to scale outside. Because while Barnes may be the epicenter of this, we need this to be able to scale outside of this university and this hospital so that other people can do it as well, so that more lives can be saved. And so we've come up with what we think is a rather creative way of handling that. And so we have a multi-center trial that we're currently building, one that is in the late stages of development, where we'll start out with something in the range of 60 some odd plus patients, and they're going to get treated all over the country and all over the world by different centers. We're going to confirm the safety and the efficacy that we've seen, but we're going to maintain control of the planning here. So in the modern age where we can take my radiotherapy plans and the CTs and the MRIs, they can be sent to us digitally, and we're going to maintain control of that so that the patients get the same quality of care, not unlike the amazing things we're doing with remote monitoring of ICUs or remote monitoring of MRIs and CTs. And that's something that we're very excited about. We're anxious to get this trial going. Patients are very anxious to get this trial going. In fact, very soberingly, we have a backlog. So we can't currently treat patients unless it's on a study right now. We're working with the FDA to do this the right way. And there's people right now, sadly, we get relatively recent requests on a regular basis of people saying, I need help today. And so we need this trial up and running. And so we've done what we can. We're writing the trial. We're getting all the regulatory stuff together. We're working with the FDA and trying to find the funding that we need to try and get that trial up and running as quickly and possible as quickly as possible for these patients that are waiting for us. And so with that, what I'm going to do is hand this back to my colleague to do a little bit of a closing statement here. Are you going to do a dance for us too? A little? No, no dance. Okay. Thank you for your time.
Great. So I won't take much more of your time. Cliff, that was absolutely out of the park. That was terrific. We want to end on looking forward. We want to think about the future. Where does this actually impact the rest of the world? And so where does this lead is the question that I asked. This is a picture of the two of us on the very first ablation that we did non-invasively. We look younger when we're in black and white, I'm told. It makes it look like an old photo. There are some ideas in medicine that you have to sell. There are some ideas that you have to convince people about. But when you compare 7 hours to 7 minutes, this idea sells itself, right? It becomes very easy to talk about. You want to be in the hospital 2 days? Or do you want to be like our last patient who came in and got his ablation on a lunch break and then went back to being a plumber and finished his jobs in the afternoon? So if we do this right, if we roll this out safely, if we deliver this like we think we can do, non-invasive cardiac radiosurgery becomes the main way that we're treating a lot of arrhythmias. It may not overtake, it may not be the ultimate way of doing it, but it becomes a very desirable way to have a cardiac ablation. And so I think the vision for the future really depends on your availability of resource. Why does that matter? Because here in the United States, we talked about the 300,000 people who might have sudden cardiac arrest in that group. But close to 5 million Americans have atrial fibrillation. AFib is the most common cause of stroke. It is a very common sort of disease. It's the #1 cause of heart rhythm disorders. And if you look at it, it's directly linked to aging. And so here is a list of 40 to 49-year-olds, men in the white bar, women in the black bar, and this is the prevalence of atrial fibrillation in that group. And you can see as we get into our 50s, 60s, 70s, 80s, and 90s, those bars only go up. We're talking about 1 in 3 to 1 in 4 patients in their 80s who will have atrial fibrillation. And so the question I ask is, when it's your turn, 7 minutes or 7 hours, where do you want this to go? Where do you want us to focus? But what about if you're not lucky enough to live in the United States or live in a developing country where you have access to these sorts of things? This is ripe for developing countries. On the left is a map of, I'll show you that when patients are no longer dependent on experienced operators like myself or expensive equipment or those catheters that you just handed across. Those are $2,000 catheters that you just had in your hands, my friends. So when you don't have access to those sorts of things, it really changes the way you're going about treating heart rhythms. There are more radiotherapy units worldwide than there are cardiac mapping systems. We are opening this possibility. If you have a radiotherapy unit, you're treating cancer and you could be treating arrhythmia. And so really what we're doing is we're democratizing cardiac ablation. We're making cardiac ablation for the people. This was the map I wanted to show you. This is South America. This is the number of practicing electrophysiologists in countries in South America. Apologize that you have to squint, but those numbers are low. In Guatemala, there is 1 electrophysiologist. I know him. He does not do ventricular tachycardia ablations because they're long and hard and dangerous. If you live in Guatemala, a country of 16 million people, you do have access to 11 radiation machines. And so there's the possibility that we could help patients using this technology in other countries. And as Cliff mentioned, we've developed the software to be able to have doctors in Guatemala upload the cardiac scans to be read by us here in St. Louis, to be able to deliver the expert care and the expert therapy at one of those 11 radiotherapy units. In Honduras, there are no cardiac electrophysiologists. It's a country of 8 million, but they have access to 7 radiation machines. So we might actually be able to move the needle across the globe if we get this right. So with that, I want to say thank you. Thank you for being here, because the future really begins here, and the future begins now. And it starts with this clinical trial to prove that we can do the things that we're talking about today. So thank you for your time. I want to have Cliff come up here and let's answer some questions. Thank you. Great. All right, good. I'm going to just kind of run through short, front to back here, if that's okay. Is that all right? All right, going back to front. Yes, sir. Great. Yeah. So the question is, what's the time frame in terms of moving this forward? We do have to work with the FDA. We just think that that's the right thing to do. We've been in close contact with them. So we have our protocol already built. We have FDA negotiations ongoing. This should be ready to go by the end of calendar year 2018. So it's there. We can't make these patients wait any longer. We're working at breakneck speed to get this moving forward. Good. Yes, sir.
My question is, what kind of radiation equipment is required? We have that proton machine. My dentist has an X-ray machine.
Right.
I mean, can anybody do it anywhere, or does it take very sophisticated equipment?
What it takes is equipment that 10 years ago would have been considered state-of-the-art, but is now becoming increasingly utilized. So it does require a machine that is capable of delivering this precise radiation, but these types of machine are no longer just available in university hospitals. They're actually everywhere. In fact, actually, we used to be the only place in the entire catchment area that could do SBRT to the lung, and we had a very busy clinic, and now the private centers are buying these machines. And while that, we can talk about competitive advantages and whatnot, the reality is that now means that patients have access. And we teach them how to do that through these trials. So by participating in the trials and having a machine like that, they can do treatment the way that we intend it to be done. Yes, sir. Yeah, you can take the first one.
Yes. Well, it does. Correct, and nor are we. But let's be very frank about this. I mean, you've seen the importance of this. You've seen patients. We have seen patients' lives get better because of this. So there are components of this that are intellectually protected. In particular, the ways that we put the scans together, the ways that we do the mapping and identify where those critical components of the arrhythmia are. What Cliff does in terms of delivering radiotherapy is something that is done in a lot of places around the world. So there's nothing, I think it's very special, but there's nothing intellectually protective of that. It's very special. So the answer is yes, there is opportunity to put our arms around this. And I think it's important. I think it's important for the university, for the hospital, for the city, for us to maintain our leadership position in this right now. Right. Thank you. Right. I think this is the part that my 11-year-old had a tough time with too, right? So right now, this is the standard of care in cardiac arrhythmia treatment. There is a scar. We need to homogenize that scar. That is, the arrhythmia goes through scar that has different properties within it. And when we ablate or heat up that area and we can homogenize the scar, make it entirely similar, then we can stop arrhythmias from moving through it. But you ask a very important question, which is, when can we build instead of burn? When can we build new tissue that's going to be good? We're not there yet. I would love to be a part of whenever we can do a leading edge from WashU who can make new cardiac myocytes that work and can link to each other and do it right. It's coming. It's coming. Right. Yeah, we as a group have been after this concept for over 2 decades now, and it's always the next promise. It's always the next promise. It is yet to deliver. It turns out it's a lot harder to engineer human cells, particularly cardiac myocytes, than we thought. So we've been at this for 25 years with the cell therapy thing. It hasn't delivered yet. I'm still hopeful. I'm an optimist. Yes, ma'am. Good question.
Yeah, so actually drawing that parallel to cancer was really an intuitive one, and I think one that runs with the way I think. Let me just first answer that by telling you that an interesting thing that we've already seen with these patients is that they have a reduction in the arrhythmia and it goes away, and then we're monitoring it over months or a year or more, and we've had some patients who are now 2 years out from this initial treatment. But it's learning to live with the same uncertainty that you would if it was cancer. We arbitrarily pick those things like 5 years. That 5-year mark that everyone throws around is something that we created for statistics so that we could compare how well somebody with breast cancer does compared to prostate cancer, compared to lung cancer. And so I think what we've seen is that it's monitoring and observing and carefully following these patients is important. We have talked extensively just about this topic this week because in Phil's world, it really is about trying to say that you've given the cure, you've given an ablation. But I hope what I try to convince you guys today about is that even if you just reduce the arrhythmia burden and they're feeling better and they're not getting shocked as often, is that not an important win? I do that every day. I treat lung cancer and brain cancer. Many of those patients will never be cured of their disease, but I'm helping them. I just treated somebody today that way. And so I think it's also thinking about what the scope is. Like what is the mark for cure? I don't know. But I do know that as we see these patients in clinic, the further they get away from that last shock, the bigger that smile gets, and the more important it is. Absolutely. Yeah. In theory. So we haven't yet had the guts to go in with radiation a second time. But that happens all the time with when Phil treats patients. I think I'll take that a next step further for you. So one of the questions we have is if a scar is where these arrhythmias are coming from, and then we're giving treatment to try and help that scar, is the arrhythmia coming back because it was going to happen anyway? Is it because the heart was getting weaker and sicker? Is it something that we did with the treatment? These are very difficult things to figure out.
Yes, sir.
No. So every patient we've treated to date, we've treated by cordoning off time on the machine and essentially paying that out of our research funds. So it's we cannot bill for this for insurance at this point. It's too early yet. As part of our discussions with our parent organizations, so for me it's this organization called ASTRO, which is the big radiation organization, and his is Heart Rhythm. We are the kind of point people now, and they are now lobbying on our behalf, and we're coming up with ways to come up with some early codes so we could start billing for this. But right now, it is entirely out of the pockets of research.
Right. Good. So if you didn't hear the question is everything that we've shown, all those patients have had ventricular tachycardia and arrhythmia from the bottom chamber of the heart, but atrial fibrillation is much more common. Have we treated anybody with AFib yet? The answer is no. And the reason for that is the risk-benefit analysis isn't right yet. Atrial fibrillation doesn't kill you, but ventricular tachycardia does. And while we're still working out the best ways to deliver focused radiation to the heart to stop arrhythmias, let's do it for the people who are at highest risk. So it would really irk me if we started doing this and it had harm that we have not yet seen because we've only been watching people for 2 years or 3 years. And we treated AFib, which is not a life-threatening heart rhythm. So there will, it does. No, you're absolutely right. So the time will come that it's on our horizon. We want to transition to that because it's a much bigger market and it's a much bigger group of patients that we could help. But the risks and the benefits aren't there yet. Good. Yes, sir. Good. So the question has to do with cardiac devices and where to put leads in the devices. And that really doesn't have anything to do with the mapping that we're doing right now. And it doesn't really have anything to do with the treatment that we're doing right now. I think the catheters that I passed around, those are the ones when we were kind of talking about putting those in the right location. Those aren't ones that stay in. They're not part of a pacemaker defibrillator unit. Those get inserted, we move them around, we heat up the tip of that, and then we take those out. To spin your question in a different way, there are some particular types of 3-wire pacemakers, right, that you can do mapping with, or that we can do mapping to see where the best location for that 3rd wire could go. We have started to use our non-invasive maps to start thinking about the best ways to use that. It turns out that the world expert on this is 4 seats to your right. Dr. Amit Noharia is one of my partners who is looking at ways of non-invasively mapping to put in those particular leads that you're talking about. Yes, sir. That's a great question. So 7 hours to 7 minutes seems unreal, and it is. And I don't know if it's as unreal for Cliff as it is for me, right? Cliff deals with this every day. Patients come in, lay down, they get their cancer treated, they get up, they walk out. But that doesn't happen in my lab. Cliff and I gave a talk at Northwestern. We were invited up there, and there was a very famous surgeon by the name of Jim Cox. Dr. Cox invented the Cox-Maze procedure. He was here in St. Louis for a long time. Dr. Cox came to our talk. When we showed him that video of the man walking out of his ablation, Dr. Cox let out a, oh! It was an audible guffaw. I'm not worried, right? I'm not worried about people being offended, because if it works, patients will not choose a 7-hour over a 7-minute. There is the possibility that guys like me who make a living twirling catheters in the heart, and we like to think we're pretty good at it, this is going to shift the way that we approach arrhythmias. But in many ways, it lines up exactly with what we do. That is, we're really good at arrhythmia ablations on most other arrhythmias. I didn't show you the good stuff. But on the arrhythmias that happen from the top chamber of the heart, we're usually pretty good at it. And on some of the bottom chamber ones, we're pretty good at as well. But it's ventricular tachycardia and that scar that we're actually not very good at with the catheter ablation. So if I was able to offload my hardest patients, my most difficult patients, my longest procedure patients, to get a different procedure so that I can focus on things that I'm excellent at, I think it's a win-win.
And I'll add, that parallel runs true with when we first started doing this for those lung cancers I showed you. So when we first started treating early stage lung cancer with SBRT, there was this fear that it was going to be this big competition and to be an all-out, knock 'em, sock 'em, duke 'em type of thing. And it turns out actually that that's not what happened at all. The thoracic surgeons, instead of focusing on those really ill patients, their sickest patients became my healthiest patients. And so that transition ended up being mutually beneficial for everybody, and so everybody got to focus on what they did best. So we've seen this happen already, and so we're hopeful that we'll see something similar with this.
Well, I'll tell you what, I think the hour is getting late. Thank you again for this opportunity. Thank you for the time and the excellent questions. Cliff and I are planning to make ourselves available here, so please come up, maybe at the bar. We're going to be back there, so come back, have another drink. Let's talk about this some more. We'd be happy to answer questions. Thank you.
Wasn't this fantastic? Just fantastic. Thank you. Thank you. And thank all of you. Thank you for your support. On behalf of the patients and families that we are so privileged to take care of, and on behalf of the physician scientists that we are so privileged to support and help, thank you for your help and support of the foundation, and thanks to the foundation team for putting on such a wonderful program. Let's enjoy and mix and mingle, all right? Thanks.